This is Chapter 10. It's going to talk about the personal, dental, and medical histories that are oh so important to every single patient appointment. So you're going to see this over and over. It's the acronym I think we talked about before. It's called ADPIDE. That's the acronym for first we assess the patient. We gather all the information, all the health history, the vitals, their perioprobe numbers, how many teeth they need that may have cavities, their x-rays. We gather all that information, pardon me, and then we can come up with a diagnosis. It's a dental hygiene diagnosis. We can't ever say a diagnosis without putting DH in front of it, because legally only a dentist can diagnose treatment, but the dental hygienist needs to be able to diagnose treatment also, and we have to call that by its right name. It's a dental hygiene diagnosis. And then we work underneath a dentist who when you work for a dentist office, you work under their license. So they know what different treatments for your patients and different ways that you can go in the treatment, and you adhere to that. So basically it is their approval is what it's saying, but we have to call it dental hygiene diagnosis just to say. So anyway, we assess and we diagnose. When we can identify what their issue is and what they need, then we can start planning. And we can start planning if their need is for restoring cavities in their mouth, then we can plan to get them scheduled for the dentist to do restorations and fillings or whatever. If we diagnose that their problem is that they need a deep cleaning, that they have periodontitis, then we can start planning all those appointments and what that entails. If we diagnose that they have absolutely no problem at all and they are so healthy, we can go ahead and plan for their next 6-month recare appointment. So first we have to gather all the information in order to be able to diagnose, in order to make the plan. And so after we've made the plan of interventions, then we can implement, then we activate the plan. That's the I part of ADPIDE, implement the plan. So we're putting it into motion. We're actually getting they come back for their appointment, we're actually scaling their teeth and doing that, or they come back for the dentist to do the fillings, etc. So after we have implemented the plan, and then we evaluate and get feedback on the effectiveness. Like let's say that we put in our notes that we used Cavitron for the first time on this patient cleaning their teeth. They were a perfectly healthy patient, but they have heard of the Cavitron ultrasonic power unit, and they wanted it used on them instead of scaling completely with the instruments alone. And so in 6 months, we're going to ask, we read that in our prior notes, and we are going to ask them then, did they remember noticing any soreness, or did they remember they're feeling better, etc. So you're going to evaluate and get feedback on every single plan that we implement. So of course we document, because documenting is an extremely important legal importance, and also just so that the patient feels comfortable with you, that you know their history and you know what they in particular need versus just cookie cutter for everybody. So it's assessment, or assess, diagnose, plan, implement, evaluate, and document. And we just made that into the word ADPIDE because you'll be asked that multiple times throughout this program and possibly on boards. So it is, this whole process, ADPIDE, is called the dental hygiene process of care. And dental hygienists across the country do adhere to this same ADPIDE. So we have the introduction, and then we have a history preparation, the questionnaire, the interview, items what we want you to include in the medical history, immediate applications of these histories, what do we do with them, and pre-treatment antibiotic prophylaxis. So the assessments, as we said before, is a collection of facts, clinical data, and dental materials related to the patient's oral health and overall health status. It's used in planning their care, a guide to all their treatment, a recollection of assessment data to evaluate, to formulate a diagnostic statement, to guide our instrumentation of what kind of instruments that we're going to use. It is the very first step in the dental hygiene process of care, and it helps us develop an individualized care plan. It identifies the health-related risks and issues, attitudes, steps for stopping or arresting oral disease processes, and prevents episodes of reoccurrence of oral disease. All of this can be had through assessing. A history is needed before an oral exam with a perio probe or explorer. Anything that we put in their mouth is even carried out. We need to have a patient history. So the use of instruments that would somehow manipulate the soft tissue, which means touch them, go underneath the gum, they call that manipulating the soft tissue around the teeth, is contraindicated if the patient needs a pre-med before treatment. So we'll get into this a little bit more, but there people that have had joint replacements or heart valve replacements have for years and years needed to take an antibiotic like amoxicillin, like 2,000 milligrams of amoxicillin, which is usually 4 pills of that before they get their teeth worked on or cleaned in a dental office. So what happens is it's bacteremia, it's endocarditis, bacterial endocarditis that can happen by introducing bacteria like into the soft tissue, in through the gums, down the sulcus, into the circulatory system. And if any bacteria then kind of goes throughout the body, throughout the circulation, and then may stop around the joints, it can cause bacteria to accumulate around these valves, etc., that have been worked on, and then they can get a bacterial infection, and that can cause a lot of problems. So just about, I don't know, 4 years ago, 5 years ago, they came out with something that said, even though for the last 25, 30 years we've been giving antibiotics for these, we have done so many studies that now we don't need a pre-medication unless their patient's doctor has specifically said that they do, and there are some cases. But for most everybody else, when you have a knee replacement or some kind of a joint replacement, it's not needed anymore. However, it's still needed for heart valve replacement and a very small list of some other things. And then you'll be given a sheet to where you'll know what things would require a pre-med. So we don't even know about this unless we get an accurate health history to begin with. If there's a question of whether or not a pre-med is needed, then you call the primary doctor first and foremost, even if it's an emergency. So the significance is that oral conditions reflect the general health of the patient. So we get a health history, and we can very much know what is, even from their entire general health, you can sometimes get a glimpse of what the oral condition might be. So it's both ways. General health influences the response to treatment, like healing, which affects the outcome. So, for instance, their general health, if they have diabetes or if they're a smoker, then their healing, we cannot expect, nor can they expect, some of the healing to be quite as rapid, if at all. So it's important that we don't give the patient false hopes, and it's important that they know this. So we can only get this through a health history. Someone's health is in constant change, and what they call that, if something is static, it stays the same. And so it is not static. It is updated at each and every appointment. Your health is constantly changing. So you may be a healthy person, but maybe you have propensity for herpes to break out when you have stress, herpes around the mouth, or, anything like that. The health, one visit you may have it to the dentist, you may have herpes, and one visit you may not. So the health is just in constant change. We update at each and every appointment, not just once a year, not just if they say that they have a problem. Every single time we see a patient, even if they just come for bite wings only, we're going to update their health history. And we need to know and take responsibility for what kind of health situation they may be in, and then act accordingly, because it may be that we no longer can give them that kind of treatment that particular day and would have to reschedule them. So the purpose is for diagnosis, precautions. We may need to modify their treatment, referrals. We may need to refer them to a specialist, their nutritional status, comparisons, and risk factors. Purposes of the history, again, appraisal of their general health, insight into their emotional attitudes or prejudices. It's evidence. If we ever have to offer legal evidence, we have it documented. It shows our beliefs in identifying cultural beliefs, which can come into, we'll get into that in a little down the road. And their ethical, racial influences, identify risk factors for oral disease. So in history preparation systems, you have several different kinds that you may be asked about. You have the interview, you have the questionnaire, or you have a combination of the interview and questionnaire. So on your pre-appointment information, that what they would get over the phone when a patient calls your office for an appointment, it's called a phone screening. And so we get basic information. Might even be able to download a questionnaire and get some information from them that way. It may be that we have them do a self-history at home. So we have them download our questionnaire that they can get online at home, and they can fill it out and bring it in, or fax it back in. So then you have a brief history. It's during a brief emergency. You would just get a brief history. So it's important, if someone comes into your office in terrible pain, you still need to get a health history. And they come in for one particular thing, you just need to make sure it matters on maybe what anesthetic that the dentist gives them, and what they can and cannot do with that patient during an emergency. And so you want to get one, but it's often cut down into just a brief. You want to always try to get the most complete history you possibly can at the very first visit or the initial visit, and then you review it afterwards, and you can get more detail. So an adequate history form, health history form, has certain characteristics. So it's going to provide for conventional notation of important details and a logical sequence. What that means is you always want to choose a health history for your office, a health history form that has a space for you to be able to write notes concerning their attitudes and knowledge of the patient, of their particular issue. You can get what their attitudes are, meaning that if they're a person that just says, I have a very busy life, I don't care what you say or what you do, I'm sure you know what you're doing, but I am only going to floss once a week, if that's their attitude. Now, we'll always be trying to change that a little bit, but we want to get what their attitudes are. Are they going to comply with home care, or are they against it, whatever. So we need a place that most forms don't have, so it's nice to have a writing space to be able to include those types of things. So it permits quick identification of the special needs of a patient. And when we record these, it's nice to have quotes. If they say, I am not going to floss, it's nice if you just put, I am not going to floss in quotations. It helps down the road, and you don't have to take a paragraph to explain what their attitude is. So it needs to be easy to file or enter into a computer and readily pulled up and available. It needs to be in the patient's own language if possible. And you can always ask if anyone speaks another language. And I will ask you if any of you speak another language. I might have already asked you this in our introductory Teams meeting, but if I forgot about it, then if anyone speaks a different language, please email me at my email and let us know, because it often helps with the patients. So, introduction to the patient. We want to educate the patient about why it's important to have a completed history, and usually you really only have to do this with patients who are a little negative about why you need such a detailed report. So you need to, at that point, let them know about the close relationship between their general health and oral health. And so you want to build some nice rapport with the patient or the parent. Explain the need for filling out a new annual health history form. So we actually update and see if there's anything different every single time that they come in. But as far as having an actual legal form that we would want them to sign saying this, that's usually updated on a yearly basis. So we explain the need for updating the health history form at each and every appointment. So we update it, but we don't need to make a new complete form with a date until it is at least a year, or if their health changes drastically. Limitations. Limitations is that it can be incomplete. Maybe your particular form doesn't have the question that is their issue or their health issue. So there can be inaccuracy or incomplete information. It may be the wording, it may be the language barrier, or the fact that they cannot really read every sentence fully. It can be a location of the data gathering, because you'd never ever gather information in the reception or waiting room because it is not private, and this is their private information that we need to respect for confidentiality and for HIPAA laws. So maybe the patient has limited patient understanding. They're not understanding all the questions on this form and all the words that they mean, but they don't want to keep asking over and over again what something means or says, or what the word means, because they feel inadequate. So they may just say no, 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 not really carrying. And you always have a reticence of some patients to disclose health information. It's important that we let them know, like if someone has hyperthyroidism versus hypothyroidism, So one is like too much of the thyroid, and one is not enough, and they take different medications. But if they need a deep cleaning, if they have hyperthyroidism, then we don't want to give them a certain type of anesthetic, an anesthetic that has a vasoconstrictor in it or epinephrine. So we don't want to give them that, where if they have hypothyroidism, then it's fine. So they don't understand why this is important, and it really is important and we just need to explain to them, that's all, in lay terms. Then you have the questionnaire. So this is any positive findings needs supplementation in a personal interview. So types of questions. These would be forms that are system-oriented, disease-oriented, culture-oriented, symptom-oriented. So system-oriented are those questions. You may have a blocked part that says, check this box if you have a disease in the digestive system, the respiratory system, the reproductive system. It will keep going on, and you just check a box. That's system-oriented. So then disease-oriented, it'll have sections that will say, have you ever had, or do you have any of the following diseases? And it was, asthma, high blood pressure, heart failure. It will be disease-oriented. And symptom-oriented would be a block that would say, check this box if are you thirsty a lot, yes or no? And if you answer yes, then to what, and explain. And that would be symptom-oriented. Culture-oriented would be more the questions that are asking about herbal preparations, and there are some certain risks to the herbal preparations because they are not, herbal preparations don't have to be guided by like the FDA or anything like that. So they don't really have a good checks and balance system. Advantages of questionnaire, it's broad in scope, it's very time saving, it's consistent, it's not under, the patient wouldn't be under pressure or eye of the interviewer. They could just answer these yes, no, yes, no, yes, no, all the way down. The patient may disclose even more information if it has spots to be able to do that. Legal documentation with the patient's signature means that even this health history is part of their legal documentation, and it would have a signature on it, and we would be able to use that if there were any legal implications. So disadvantages without follow-up. If you don't follow it up and you would just say, check off these boxes in the waiting room, bring them into me, and then you just, fill them in, the questions in on the computer, but you don't actually follow up with questions about this, it's very impersonal, number one. It's not catered to their particular need. There's no opportunity to develop a rapport with your patient. It's very inflexible. There's no chance for additional questioning in areas of importance to you or to the patient. So we always take a questionnaire and then follow up. Oh, I see that you say that you have asthma. Do you have your inhaler with you? And you can go ahead and ask different questions that will follow up, etc. Or I see you've checked thyroid issues. Do you have hypothyroid or hyperthyroid? I see you've checked diabetes. Are you type 1 or type 2? Okay, so that helps us with knowing of possible emergencies or already knowing where we keep sugar in case they were hypoglycemic, etc. So the interview, the participants are alone with you, hopefully as alone with you as you can get. Some offices do not have walls that go all the way to the ceiling, so it's not like a completely private, but we need not to do it If that's the case, we need to keep our voice low so that we're not spreading their personal information down the hallway. So this is something we do alone with the patient, never ever in the reception room in front of other patients. Start asking them about their health history. You'll either do it in the op, or some offices may have a consultation room. Most, I think, will do it in your own operatory. Pointers to that: be friendly, understanding. Do not look like you're judging anything that they say to you. Be reassuring, accepting, tactful, genuine interest, and build rapport. So on the form, try not to simply read from a list of topics, which is super impersonal. Try to at least put a little bit of personal swag in there somewhere. So the best type of interview, between the interview and the questionnaire, it's the best type of interview that you could possibly give a patient is a combination, as you can see now, of the questionnaire, where they list things and it makes it time efficient and consistent, and then you might interview questions that they've answered yes to. So advantages and disadvantages of the interview. The advantage is personal contact develops rapport, flexibility for the patient to ask questions with just the interview. The disadvantages is it can be really time consuming. You can be developing such a rapport with your patient that the time is ticking away, and now you have hardly any time. You've got 15 minutes left to actually clean. You can be becoming so friendly, and then they become friendly, and they start talking and talking and talking, and you find it hard to get them to wrap it up, and you feel rude if you ask them, but you're watching the clock and are getting very anxious because you have talked through and have become super friendly through most of your appointment, like we said. So omission of items of importance may not be listed on that interview if you only do it by that way, and it could be embarrassing to the patient. So the personal history, we collect the data collection and their name, address, phone, marital status, birth date, occupation, who their doctor is, gender, name of guardian, etc. So we're going to collect that, and that's usually collected in a little paragraph on the very front of a medical history with all their personal information. So we have to identify the need for approval of care of a minor. So if it's a minor patient, we have, if the parent just drops them off, then we have no okay from them to go ahead and do x-rays, etc. So we've got to be sure, if it's a minor patient, that we take care of that before a patient may leave and come back. So we need to know if there's a need for physician consultation. So culturally appropriate communication determination. And what this means is if they speak just a little English or a little of your language, do they speak enough that you can be asking them all these questions without an interpreter? So for instance, we have a lot of other languages spoken in our clinic, and we always ask them to bring an interpreter, because otherwise a person can't agree to anything or disagree to anything if they're not understanding what you're asking them. So we always ask, first of all, in the dental history, for their chief complaint. It's the cause of any pain. Are you in pain? Even if they come for a regular cleaning, we'll say, are you in any pain? At the very beginning. And if they say, we abbreviate this by CC and in our notes, and if they have a chief complaint, then whatever is in pain needs to be dealt with first before you start cleaning their teeth. We need to address what's causing them pain, and then we can go elsewhere. So we want to know their previous dental and preventive care as described by the patient. Have you ever had any bad experiences? Because that may lead to a person who's had super bad experiences in their youth might be really, really scared to get an injection, or they think everything is going to hurt them a lot. So we need to know what this is in their own words, to be able to help them relax and go through our appointments. So risk assessment forms are very helpful. They call these risk assessment for like dental caries. How are they susceptible to dental caries or other things? And we'll have these in the clinic at a later form in other terms that you will be introduced to are these risk assessment forms. Patient attitude toward oral health may be indicated by previous experience and family history. Their personal daily care. You'll be able to tell what kind of values are placed on their teeth and their attitude toward it. And hopefully not through speeches or sarcasm or belittling at all, but through just very reassurance and acceptance, and to wherever you're willing to meet them, wherever they are today in their attitude. And just hopefully you'll be able to explain through their care in your practice of the different values and the reasons that certain things matter that can change their behavior. And it'll help us know the patient's current health beliefs, if they're cultural or not. So medical history determines whether the patient has had any condition in the following categories. Conditions that may complicate dental care, disease requiring special precautions or pre-medications like a heart defect, conditions requiring medicating drugs, which would be your pre-med or your pre-medication before your appointment. This is IE, which is infectious endocarditis, and what we talked about with the heart valves, etc. There are some that need to take an antibiotic, but if let's say that they're already taking an antibiotic, amoxicillin for strep throat or something that they already have, and then they come to you and they need a pre-med, and they say, oh, I didn't take my other pre-med, but don't worry about it because I'm already on antibiotics. I've been taking them for 4 days for strep throat and are going to continue another 6. That isn't good for a pre-med. You can't, the pre-med that they need cannot be one that they're currently taking for a disease. It has to be a different class of antibiotics for the pre-med. Okay, so we want, they can take it before or after an appointment, at least 2 hours, an hour before or 2 hours after the appointment. Contraindicated care. And remember that indicated means something that you would want them. It's indicated for them to do. Contra is against, which would be not indicated. Something that would not be indicated for them to do, not be right for them to do, would be a word called contraindicated. So anticoagulants require consultation with an MD before treatment, and antihypertensive drugs may alter any local anesthetic that you may get them. So hypertension is blood pressure, so any anti-high blood pressure drugs, certain ones may alter the local anesthetic. So that would all be important to know. And anticoagulants would be blood thinners that they may need if they have a propensity to heart attack and blood clots, etc. They may be taking an anticoagulant, and sometimes we may need to call their doctor to see if it's okay that they are taking these blood thinners before their dental treatment. Some doctors will say have them stop taking their anticoagulant day before their dental treatment, and some will say no, it's too important for that patient. They need to keep taking it. And what the indication of this would be, an anticoagulant or a blood thinner, when you're up in the gums getting a deep cleaning, it just means they're going to bleed and bleed and bleed, you know, and we don't want that to become a problem to where we maybe can't stop the bleeding. And so that's why it might require a consultation with an MD to whether it's important for them to do or not. So the medical history, their gender, ethic, racial influence. This is because we like to know this. African Americans and American Indians have increased risk for diabetes and perio. It doesn't mean that everyone from those ethnic backgrounds or influences are going to have that, but it means that they have an increased risk for it, and so you need to be kind of looking for that. If they're showing certain symptoms of they're hard to heal, maybe they don't go to the dentist or doctor very much or have never been, so they haven't really been checked for diabetes or perio disease. So things that you see in your office may have an indication that this is in fact maybe what they have, and maybe they need to go see a doctor at this point. So it also lets us know if they're allergic or have untoward reactions to medications, which untoward means something that is not good, something that is not safe, or bad reactions. Diseases or drugs that have oral manifestations. We can see someone's gums. There's an for epilepsy, and they have a lot of seizures, and so there's an anti-seizure medication that works really, really great to control seizures, but it can also cause your gums, your papilla in your gums, to become super, super swollen and look like there is some kind of a disease. And so you may look at their mouth and think, oh my goodness, you know, what is it that they have? But because you have this medical history, you may know, oh, they're on an anti-seizure medicine. So that's not because they're not taking care of their teeth. It's the meds. So it helps to know all of these things. If they have communicable diseases, they say TB and herpes, etc., but TB is something that someone with TB has already been told that they should never be in a normal dental office to get a cleaning. They need to be in a specialized office for patients with tuberculosis and in closed off rooms with ventilations and all sorts of things for the tuberculosis. So we shouldn't be seeing anybody with tuberculosis. You will, however, see a lot of people who will say, I had tuberculosis 20 years ago. And these people are fine to treat. We don't have to worry about that. But you won't be seeing anybody with active tuberculosis, but you will be seeing some people who have herpes, and then we'll turn them away if it's active herpes and reschedule them because it's very communicable. So physiological status of the patient. We know whether they're pregnant, whether they're maybe going through puberty, menopause, birth control. All of these things can have, they don't always have, but can have an oral manifestation in the mouth, as far as whether, you know, someone who's pregnant, their gums can be a little puffy and bleed really super easy, and when they stop, when they give birth or stop nursing, then it all goes back to normal. So there's certain kind of that could be some kind of an oral manifestation to almost everything. So if someone's pregnant, you don't want to give them huge lectures about the fact that they're not taking care of their teeth. They may be taking care of them great. It's just that they're pregnant. So that gives us an idea. Medical consultation, telephone or personal contact for urgent treatment. You want to follow up in writing or fax or mailed copy regarding the advice given for legal reasons. A written request, there's a letter of a formal request is preferred for a medical consultation for legal issues. They can be mailed or faxed, but very often, if we want to know from a medical doctor, we may call them to get their see what they have to say. Most of the time, they're not going to be able to come to the phone. They'll be busy in their own practice. But we need to have a letter of formal request asking about a medical consultation about a patient for legal issues. So referrals, when signs of possible disease is apparent or tests are needed, then we may need to refer them to a specialist. Radiation, current or recent therapy. You want to always consult with the person's oncologist, which is their cancer doctor, for the amount of radiographic radiation that patient can have at that moment if they are already on radiation therapy or have recently had radiation due to some type of cancer. So it's our responsibility to utilize all available clinical, assessment, and health history information when we are thinking about whether this person needs diagnostic films or not. Now we're going to talk about the prophylactic pre-medication. Prophylactic is just the word for you're going to give this pre-medication, especially before you have any kind of dental treatment. So we've already talked about the risk of infectious endocarditis, which is IE. And what it does is it's any kind of tissue manipulation. So we don't even have to scale a tooth. We can just put an explorer or a perio probe or be touching the gums, and that's considered tissue manipulation around a tooth. And so we can cause bacteremia, bacteria to get into the blood. And that's what the pre-med, the antibiotic, is given to them, so it prevents this bacteremia from going all over to the particular valve that has been replaced, etc. So timing of the ingestion of these oral antibiotics ensures that there's an adequate concentrations in the blood during and immediately following the actual instrumentation. So it's important that they don't say, yes, I took it 4 hours ago. We want them to take it at least an hour before and up to 2 hours after, so that there'll be adequate concentrations of that antibiotic in their blood. It's the whole point. So if they're already on an antibiotic, like I already talked about, then they need to take a different family type of antibiotic for this pre-med. So you can look at box 210 on page 168 for some help on what that's about, different issues that would require a pre-med. So if the patient has a heart condition but says they don't need to take a pre-med antibiotic, we need to confer with the doctor, their MD. So they may need to reappoint that particular patient in the dental office. So we ask the MD for a written documentation stating whether the patient does or does not require an antibiotic medication, because they've stopped a lot of these, and so that's great, but sometimes the patient just doesn't want to make the hour trip again, and so they may just say, my doctor just said I didn't need to, etc. So we need to get this always in written form. To avoid reappointments from patients forgetting to take their pre-med, one thing that can be done is in the telephone screening by the person who is scheduling the dental appointment. So if it's a new patient, you could ask them as one of the questions, are you ever in need of taking a pre-medication or an antibiotic before you have dental treatment? And they'll quickly enough tell you yes or no. So a lot of this, people having to reappoint people and send them home, is if the telephone screening by the person who's doing the appointment can just ask those questions. And if it's a person that comes back, has been coming to your office for 5 years, every time that you talk to them about a new appointment, you just remind the existing patient. So conditions at risk for endocarditis, their periodontal status and risk. The risk of endocarditis is much greater in mouths with ongoing perio infection than when the perio tissues are healthy. So an individualized care plan as specific recommendations are possible to define for all patients. So discrimination in use of antibiotics. Routine use is never indicated of antibiotics because people are developing tachyphylaxis, which is that they're developing the antibiotics don't work great for them anymore because they are, it's a tolerance level thing. So sometimes the patient is less at risk from a dental procedure than from potential side effects of the antibiotic. Okay, so the American Heart Association, the AHA, and the ADA, which is the American Dental Association, have the most current pre-med guidelines, and they're stated from 2017 at these two websites. You can look that up and forever look these up at these particular sites because they will have the pre-med medication guidelines for endocarditis always given there. So I don't think it's changed much since 2017, so they are just keeping that year as the latest year. So they have recommendations for all procedures likely to induce gingival bleeding, prophylaxis for dental hygiene procedures. Mouth rinses were always told that they could help reduce the bacteria in the mouth. Now that's being questioned whether that's really all that effective these days. So daily biofilm removal may reduce the infectious endocarditis cases more than anything. So if they are just brushing their teeth at least twice a day in the correct way, that may be the best of all to reduce the bacteria in their mouth. So the New Age American Heart Association and ADA guidelines says no evidence-based method to decide exactly which procedures require prophylactic pre-medication and which do not need it. So limited control research factors would be that there's a low incidence of infective endocarditis, and the incidence when an antibiotic pre-med did not prevent infectious endocarditis following a dental invasive procedure. So updated list in the last few years. These are procedures for which a prophylaxis is recommended. Is any kind of manipulation of the gingiva or teeth, the periapical region of the teeth, the perforation of the oral mucosa need antibiotic pre-meds, previous infectious endocarditis, or if you need to consult a medical doctor. Cardiac conditions associated with the highest risk of adverse outcomes from endocarditis, such as cardiac transplants with abnormal valves, or prosthetic cardiac valve and repair. That is really important. And once again, you can review box 10.2. Procedures deemed not necessary for antibiotic coverage now are local anesthesia through non-infective tissue. You don't have to give a pre-med if you're going to be exposing intraoral radiographs. You don't need pre-med antibiotic if there's a replacement of orthodontic appliances or brackets. If you are have band adjustments. If you are shedding of the primary teeth, bleeding from trauma to lip or oral mucosa. These do not need them anymore. So the ASA is the American Society of Anesthesiologists, and they are the ones also who have the ASA categories of health. So you're going to want to refer to a handout. The categories 1 through 6, it's an overall estimate of their medical risk. They have ASA 6 and ASA E3. E3 means an emergency of any variety. So the ASA 1 is without apparent systemic disease. This would be the normal healthy patient. ASA 2, they'll have a mild systemic disease of maybe one thing or just a mild. ASA 3 this is with a more severe systemic disease or multiple systemic diseases, like they have heart and liver, etc. But it's not incapacitating. ASA 4 would be a patient with an incapacitating systemic disease that's a constant threat to their life. You're not going to be seeing many of those. I had several in my private practice that were in a wheelchair, that had congestive heart failure, that were wheeled in to have their teeth cleaned, but it's very rare that you'll be seeing a lot of those in your practice, and certainly around the clinic. Then you have ASA 5, which is a moribund patient. This is bedridden patient that's not expected to survive even 24 hours with or without any kind of care. You're not going to be seeing any ASA 5s. ASA 6, you won't be seeing any of those either. That's brain dead waiting for their organs to be harvested. So that wraps it up on the health history. Hope you understand that there's a huge importance on getting accurate information every single time a patient comes in, and we'll be doing some role play in the clinic about this.